seeing a patient with one of these prolonged symptoms, what should we be doing in our office in advance of sending the patient to an otolaryngologist as far as our physical examination?
Well, the physical examination, of course, is the cornerstone for diagnosis of these tumors. These tumors arise from mucosal-based surfaces in the head and neck, and quite honestly, many of these areas are very accessible to examination, even in a routine office setting, using just techniques of direct visualization and, importantly, palpation as well.
Thanks, Amit. Now let's meet Dr. Agrawal's patient, Earl, who's got an 80-pack-year history of smoking and presented with a sore throat.
Earl, thank you for joining us today and being a part of our program. Tell me about your initial examination with the family doctor.
Well, I started out with a sore throat in September. I went to the doctor and he gave me some antibiotics, which didn't seem to help. So in January, I kept going back, and in January I went to the doctor again, and I said, something's wrong, it's not doing it. And he again checked me and through my ears and my throat, and he said, well, there is a redness there. He said, why don't I send you to Dr. Bailey?
Tell me about your initial visit with the ear, nose, and throat physician.
He took a mirror down my throat and a camera down my nose, and that's when he told me, he said, I think you got cancer on your voice box, but he said, I can't say nothing until after I do a biopsy. And I said, okay. Well, I understand that because, you know, I mean, they could scare you or whatever, I imagine. But I went into it on the understanding that, to my own, that whatever it was, let's get rid of it, you know.
Now, although Dr. Bailey did do a biopsy and it was negative, he was still pretty worried, wasn't he?
He was worried because he still felt, after going through my nose, that it was something on top of my voice box.
Earl, I know you were a long-time smoker. Tell me a little bit about your smoking habits.
Well, I started smoking when I was about 15. I'm 56 now, and I averaged about 2 packs of cigarettes a day. So you're talking 40, 42 years.
Earl is a 56-year-old gentleman who presented to his family physician with a 2-week history of sore throat. Ultimately, he was referred to his local ear, nose, and throat physician, who was suspicious of the diagnosis of laryngeal cancer. Although Earl has a 40-year history of tobacco use, he is otherwise medically healthy and reports good exercise capacity. On examination, Earl was noted to have a suspicious lesion involving his supraglottic larynx, which did not appear to involve his true vocal cords. He had no clinical or radiographic evidence of metastatic disease. Because of his good functional capacity, he was felt to be a good candidate for conservation laryngeal surgery. Ultimately, Earl underwent endoscopy and biopsy of his larynx, which confirmed the presence of squamous cell carcinoma. In order to better understand how modern head and neck cancer therapy is currently applied, it is important to review some of the basic fundamentals regarding diagnosis and staging of this disease. In the majority of cases, cancer of the head and neck affects the upper aerodigestive tract, that is, oral cavity, oropharynx, larynx, and hypopharynx. Other head and neck malignancies include cancers of the face and scalp, tumors of the nose, paranasal sinuses, and nasopharynx, cancers of the thyroid and salivary glands, as well as primary and secondary cancers that involve cervical lymph nodes. When I examine a patient, I begin by observing general appearance, respiratory effort or presence of stridor, voice quality, and a general inspection of the skin of the face, scalp, and neck. Individual cranial nerve exam testing should also be done. The ear should be inspected for canal lesions or middle ear effusion. The anterior nose can be similarly inspected for lesions without discomfort. In order to examine the oral cavity and pharynx, I find that using clean gauze to grasp and retract the tongue and tongue depressors are useful. The lips, gums, dentition, cheeks, floor of mouth, tongue, tongue base, palate, tonsillar fossa, and posterior pharynx can be visualized or palpated. It is very important not only to look, but also palpate many of these areas. For example, the tongue base, where lesions, even if difficult to identify visually, can often be easily appreciated upon palpation. Assessing for neck masses or adenopathy involves palpation of salivary glands, submandibular, upper, middle, and lower jugular, posterior cervical, supraclavicular, and central neck regions, including the thyroid and trachea, using bimanual technique whenever feasible. Detailed examination of the larynx and hypopharynx requires specific training and experience and is difficult for most clinicians to perform adequately and is usually left to the head and neck specialist. For most patients, I utilize indirect exam of these areas with a laryngeal mirror although in some cases proper evaluation requires the use of endoscopic means, which can be carried out in the office with minimal discomfort using topical anesthesia.